From the JAMA Network, this is JAMA Otolaryngology Head and Neck Surgery Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Otolaryngology Head and Neck Surgery.
Hello, and welcome to our listeners around the world. You're listening to JAMA Otolaryngology Head and Neck Surgery Author Interviews. Thanks for joining us. I'm Dr. Paul Bryson. I'm the director of the Cleveland Clinic Voice Center. And today I am joined by three very special colleagues and thought leaders with regards to many things, but specifically today we're going to talk about patients with tracheostomies. And today I'm joined by Dr. David Francis, who's a professor of otolaryngology, head and neck surgery, and vice chair of academic affairs at the University of Wisconsin-Madison. Welcome to the podcast, David.
Good to be here.
And Dr. Joshua Bedwell, who's an associate professor of otolaryngology at the Baylor College of Medicine. And he also serves as chief surgical quality and safety officer at the Texas Children's Hospital in Houston. Welcome, Dr. Bedwell.
Thank you so much.
And then finally, Dr. Philip Weissbrod, who is the professor and chair of the Department of Otolaryngology, Head and Neck Surgery at the University of California in San Diego. Welcome to the podcast, Phil.
Thanks for the intro, Dr. Bryson.
The topic today, and a really clever title for this very important article, is Uncoded and Underserved, Impacting Care and Quality in Research. And this specifically is about patients who receive a tracheostomy. And you can find a link to this article in the episode's description. And it'll include adults and children. And I think all of us have experienced a number of phenomenon around trying to do research in these patients and then also provide care sometimes in an ongoing setting. So I was hoping, if you would, Dr. Francis, lay out the issue as you see it when you look at the concepts of being undercoded and thus underserved.
Yeah, thanks, Paul. Tracheostomy is a very common procedure that's done in the hospital. It gets estimated about 100,000 tracheostomies are done per year in the United States. I think that's just in adults, actually. But basically, those patients are usually very sick people, and they're coming in the ICU and they're intubated for a while, and then they ultimately need a trach. Unfortunately, about 20% of those folks pass away while they're in the hospital, but the other 80%, it's unclear what happens to them. Some may get decannulated, meaning their trach may be removed while they're in the hospital, but a large majority do end up being discharged from the hospital with a piece of plastic sticking out of their neck into their airway. And often they'll go to skilled nursing facilities or to home. And the hard part about this is there's not a organized, systematic way of tracking those people with this piece of plastic in their neck that's directly connected to their trachea. And that's a big problem because it's dangerous. And lots of things can go wrong with a trach in your neck if it's not cared for properly. And so that really is the impetus for all of this. And unfortunately, because of the severity of the problem, it's surprising to us that there's not really a way to track that epidemiologically in studies. There's not systematic ways that hospitals have designed to bring patients back necessarily. And there's no way of reimbursing it, which basically results in not being prioritized. So I think those are the big things that we are worried about when we're talking about this patient population, but primarily it's a safety issue. If we can't define the safety issue, it makes it very difficult to improve it.
Yeah, thanks for that perspective. Talking about outcomes and other research, Phil, I know you have embarked on a number of longer-term studies. Can you comment a little bit on, what's the difficulty when you go back to try, like David said, look at the outcomes in these patients or even identify them and find them after they leave the hospital? What's been your experience when you've tried to do these bigger projects?
Yeah, thanks, Paul. I think what you're referring to is a number of years ago, we established a group of university centers that looked at their own tracheostomy patient populations. And part of that effort was to look at what happens while they're in the hospital to understand who's doing the work and how patients are being taken care of after the OR and what their outcomes look like. But similarly, when you look at those patients as they leave the hospital, as Dave mentioned, there's really a black box as to what happens to them. They, without appropriate coding of understanding tracheostomy exchange and decannulation, you don't really know what's happening. And if we look further afield at other communities or countries that are studying these, there are countries around the world that do a little bit of a better job than we do. Specifically, the UK and Canada have patient-centered registries, but nowhere around the world are we doing a really good job at documenting what happens to this population. And this is such a significant issue for patients that leave the hospital with a tracheostomy. This is a major factor in terms of quality of life, in terms of system resource utilization, and really can be very, very impactful. And so when you start asking sort of the big questions about what happens to these patients, who's taking care of them, we just don't really have a great capacity to answer these questions. And there have been a number of groups to try to answer this, point specifically like Global Tracheostomy Collaborative. But you also have to remember that the groups that participate in those studies are very motivated and engaged in answering these questions and maybe don't represent what really happens in the communities at large. And so as we've started to think about how to answer some of these questions, we really feel like having coding to represent what happens to these patients as they leave the hospital will allow us to make a lot of positive change, both from the system, from the patient perspective, and from the provider perspective.
Josh, in your role looking after children with tracheostomies, but then also certainly in your role as the chief quality and safety officer, what are you seeing in our pediatric populations? And what's your sense at a system level for wanting to look into some of these issues?
Thanks, Paul. I think from a pediatric perspective, there is a great deal of interest in developing best practices for decannulation pathways, as well as standardized tracheostomy care pathways. And specifically speaking about decannulation, without having a codable event, it makes it very, very difficult to analyze practice patterns at scale. The largest publication that we have about decannulation patterns, not just in children, but across the world, comes from the Global Tracheostomy Collaborative. That's about 5,000 patients across the world. But that is a very resource-intensive way to get information about variations in practice. From my perspective in quality improvement, we know that you can't really improve what you can't measure. And right now, it is very difficult to measure decannulation, and it's next to impossible to measure the frequency at which and the outcomes of routine tracheostomy tube changes that happen either in the hospital or in the office. So I think from a QI perspective, it is really imperative that we figure out a way to code these events so that we can study them and identify variations and best practices across the nation.
When you all look across your health systems, like you said earlier, David, like 100,000 trachs a year, we interface a lot with our intensivist colleagues, right? Both for consultation when trachs are difficult or perhaps to perform a tracheostomy. When we look outside of our specialty, do you think there's an appetite for broader collaboration in looking after these patients? I know that some health systems are more integrated. Other regions of our country are very fragmented with the care that vulnerable populations receive. What's your sense for how we might partner with some other specialties to try to help?
I can try to take a first stab at that. I mean, I think there is an appetite. There's a lot of different specialties that perform tracheotomies, and there's a lot of different specialties who care for patients with tracheotomies. I think they all have their view of their part of the care process where they take care of people. ICU doctors think about the ICU care they're going to provide them. We think about the procedure, or if we have a head and neck cancer patient with the tracheotomy. It's hard because everyone's, like you said, a little fragmented in the way we care for patients. When they get to the point of discharge, that's when things tend to fall apart in my mind, because there's been maybe 2 or 3 teams that have cared for this patient, and then they get sent to a skilled nursing facility, and then it's starting over again. So I think there's an appetite. I don't think there's an awareness as much as there needs to be of the need for this, because I don't think it's on the front of people's minds because of the way we practice medicine. And so I think if we work together and if we elevate this problem like we're doing today, I think it can be very valuable as we're trying to develop these collaborations across specialties.
Yeah, Phil.
Yeah, if I may add to that, I think there's real value here in creating a multidisciplinary effort. I can speak to my own institution. The interventional pulmonary group is very integrated into tracheostomy care and does a really good job of follow-up, to give them a compliment if they're out there listening. But I will also say that in order for us to be successful in thinking about how to really answer these questions, we have to be engaging of all the groups that do this work, whether that's trauma surgeons or thoracic surgeons or general surgeons or otolaryngology head and neck surgeons or intensivists. This is going to be a group effort. And I think as otolaryngologists, we are uniquely positioned, or perhaps along with our interventional pulmonary colleagues, to really see the after effects of those individuals who don't get regular care. And perhaps that's maybe why we need to drive the conversation. But I think it will be very important for us to be engaged with those other groups and societies as we seek to come up with a solution.
I wanted to ask you all too, at the advocacy level, it's uncoded, which one, it limits tracking, two, it's not compensated care a lot of the time, or it's hidden in other sorts of, coding and reimbursement mechanisms. What does it take at the advocacy level to get a new code or to design a visit that is then trackable in the system? Josh, any comments on that?
My first comment would be that we've learned very quickly that it's quite complex to get a new code. All right. The process is seemingly straightforward, but there are lots of competing interests and competing priorities that our organizations and societies have to face. And so to propose the creation of a new code is no small thing. But I think that's why I appreciate how David and Phil have really outlined the seriousness of the problem and why we feel that it is worth going through this somewhat onerous process of advocating for these new codes.
Well, I really appreciate everybody's time today and expertise. As we conclude our podcast time today, any take-home messages or points that you each might want to make for the listener, as they contemplate this line of care at their own institutions?
From my perspective, the biggest thing is this is an opportunity. It's a clear opportunity to do something to improve patient care. And it's low-hanging fruit. I mean, this is not something that should be complicated, should not be controversial. This is something where we can improve care by measuring something. And as Josh mentioned, if we can't measure it, we can't improve it. And so very few people would argue with that. So I think to me, getting this message out there, this is an underserved, under-recognized group of people that need our help, and it requires us to work as a group, is not controversial at all. It's common sense. But the issue has to be elevated. People have to recognize that this is something that needs to be addressed, and it's going to take some effort and some foresight. And so that's probably what I would say mostly about this. That was the intent of our paper. It's also something that we've been working on as a group for a long time, both in otolaryngology, but also I think across subspecialties who have come across complications and issues related to tracheostomy care.
I think if I could leave us with one thing, it would be that the way our system is set up now, we treat tracheostomy like it's a one-time event, one and done. And for our patients, both in the pediatric world, which I'm a part, and in our adult patients who are living with tracheostomy, it is not a one-time event. It's the start of a long journey. And I think that this proposal is a way to recognize that trach care is a chronic and ongoing issue.
I may also comment, thanks, I totally agree with both Dave and Josh in their statements. The other thing that I would really like to highlight is that we have a predicate for this. This is not a novel concept, and I think anybody that's done long-term tracheostomy care probably has had this very same thought of Why is there no code for me to take on this new patient that has a challenging airway? And this concept applies outside of our own field. When you look at other providers who work in other spaces, specifically gastrostomy and urologic Foley catheters, these codes exist. And they exist for a reason, because it's important to be able to track, improve the quality of the care that we provide. And so we're really just trying to bring tracheostomy care into alignment with what's out there for other similar devices.
That's a great point. There's a lot of patients that have chronic medical conditions that involve devices, and why not the tracheostomized patient? Well, it's been great to have you here today. I'm Dr. Paul Bryson, and I've been speaking with Doctors David Francis, Joshua Bedwell, and Philip Weissbrod about improving tracheostomy care. You can find a link to the article in this episode's description. This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.